Hi, so today's lecture is going to be about hypertrophic pyloric stenosis, and there are a few points that we have to cover before we can get into the disease itself. So the stomach has three parts, obviously, that we all know of. This is the esophagus, um, then it goes deep, and here is the diaphragm. It has to be 3 to 5 centimeters, the intra-abdominal part of the esophagus, and then this is the stomach. Obviously, we have the fundus, we have the cardiac, and then we have the antrum, and then we have the pylorus, obviously. So antrum, fundus, cardiac, or the body of the stomach, and then the pylorus, and then it continues as the duodenum. Correct? That is something we all know of. Now, first part, second part, third part, fourth part. All right, basic stuff. What I really am interested in is that this pylorus. Okay, so when it undergoes hypertrophy, what happens is that the muscle, the lumen, okay, the muscle is undergoing hypertrophy, the pyloric muscle. Okay, and because of that, there is stenosis. That means whatever content that is entering the stomach cannot leave into the duodenum. Why does this occur? Well, it's congenital, sometime, in most cases, at least, and it's also associated. A very important point is that it's associated with erythromycin. So, if the mother takes erythromycin during pregnancy, that's a very high yield point. So it can lead to hypertrophic pyloric stenosis. Also, a very important point is when you're talking about the pyloric stenosis, it's usually in males greater than females. Okay, it's due to erythromycin, as I already mentioned, erythromycin, and it's associated in the firstborn male child. So if you're the firstborn male child, probably there's a higher risk of you getting this. Okay, also associated with trisomy 18. Trisomy 18 is called Edward syndrome. It's also associated with Cornelia de Lange syndrome. Not so important. So, what is the pathogenesis? The pathogenesis is simple: hypertrophy of the pylorus, may be due to lack of sodium, due to decreased sodium, due to decreased nitric oxide synthase. We know arginine, nitric oxide synthase, we get nitric oxide, vasodilation, muscle relaxation. We know about that via the CGMP pathway, basic stuff, correct? So, that about being it. Okay. So, the pathogenesis and all is pretty simple. Let's get into the features. Okay. What does the patient present with? Okay. So, the patient at birth is normal. Okay, so after 2 to 3 weeks, he has he slash she, I'll say he because male is more firstborn male child, he has non-bilious vomiting. Why non-bilious? Because bile cannot enter the stomach. The bile opens up into the second part of duodenum, and that's basic. Okay, right? So the bile opens up into the second part of duodenum out here, correct? So because the food is being regurgitated or vomited from here, obviously we won't have bilious vomiting. And this non-bilious vomiting is projectile. Why is it projectile? Because of the force of contraction being very severe. All right, that being another very important DD. Is there going to be any protein energy malnutrition? No, there's not going to be any protein energy malnutrition. Okay, that's very important. How do you want to diagnose this condition? You want to just do you can do it on examination. You ask the mother to feed. When the mother feeds, you can actually see the peristalsis of the stomach, and then you can palpate an olive like mass, which is actually the pylorus. And then after that, the kid will have projectile vomiting, but this is such a non-ethical way to do it. Projectile vomiting, making the child go through a series of vomiting. So that's why what we do is, obviously you can see the peristalsis from the left to the right because of the anatomy of the stomach, correct, in this direction. from left to right. Nevertheless, you will see projectile vomiting, that's for sure. Okay, so how do you want to diagnose it? One was on examination, and I'm just letting you know in case this comes as a clinical vignette. But you should definitely know that you can do a USG ultrasonography, or also you can do an X-ray, and then on an X-ray you will see a single bubble. So a double bubble is seen in duodenal atresia, a triple bubble is seen in jejunal atresia, a soap bubble is seen in meconium ileus. This is just MCQ points that should be remembered. Okay, we can do that. Okay, you can see a single bubble, and you can obviously do a barium study. You can do a barium study, barium meal, all of that. Okay, what else? What after you've diagnosed this, what is the blood findings that you will see, or serum findings, blood/serum? Okay, because of vomiting, because of intense vomiting, you're going to have hypochloremia. Because of that, you'll have you will have first you will have let me go and see order. Okay, so because the HCl that is being secreted or that's being vomited from the stomach, first you'll have hypochloremia. Okay, so let's say this is the stomach. Okay, I'm just making a stomach as a bag. So the chlorine is present, the H is present in the form of HCl. Both of them are going to go out. Okay, from imagine the stomach to be a bottle. So first you'll have hypochloremia, plus you will have metabolic alkalosis, because all the acid is being lost. Correct. Now what happens is that because of low chlorine, okay, and because of low levels of hydrogen or acid, what you will have is that your renal compensation begins. Okay, now usually with chlorine some amount of sodium is also lost, but that's not what I'm trying to say. What I'm getting at is that because of renal compensation, in metabolic acidosis, okay, because of metabolic acidosis, we are going to try to reverse that condition. Correct, we are going to try to reverse that condition. So what happens is that the renal compensation mechanism begins, and what it aims at is to increase the excretion of bicarbonate. Correct. So when bicarbonate starts being excreted, okay, so sodium and bicarbonate both are lost in the urine. Okay, so sodium and bicarbonate lost in urine. Okay, so that leads to hyponatremia. Okay, why is sodium lost? I'm telling you, I'm saying it again. Let me just draw the entire mechanism. Okay, so let's say if this is your GFR and you've had your H plus that's entering. Okay, you do not want, so anyways you have low levels of H plus, so H plus that's entering is already very low in its amount. Okay, so you have bicarbonate also being lost. Okay, and out here you have a carbonic anhydrase, and also in the lumen. So the ideally what happens is that H and H bicarbonate get, usually what happens is that carbon dioxide is formed, and carbon dioxide mixes with water, it forms bicarbonate. Bicarbonate breaks down to form H plus and HCO3. H plus is secreted out, HCO3 binds and again is taken in as bicarbonate, and this process goes on and on. But because here we are trying to reverse the entire mechanism of metabolic alkalosis, we need to make sure that the bicarbonate is lost, and in that case we are not trying to absorb bicarbonate, so this carbonic anhydrase is not function and bicarbonate just is excreted out. Now because bicarbonate is excreted out, obviously you are trying to, so you're losing out bicarbonate, so you would think that the urine is going to be alkaline. You think that the urine is alkaline, but what happens is that looking at the hyponatremic condition, what happens is that there is going to be activation of RAAS. Now this RAAS is going to stimulate aldosterone, and aldosterone is going to cause increased uptake of sodium. Okay, sodium uptake, and it's going to cause hypokalemia. Okay, because when aldosterone acts on the tubule, let's say this is going to increase sodium, and it's going to increase potassium and hydrogen. So because it's also going to cause increase H plus excretion, the urine is not alkaline, is acidic. So the patient will present to you with a classic case of hypokalemia, hypochloremia, hypo uh, natremia may be there, may not be there, depending on what stage it is at. Definitely metabolic alkalosis is there, but paradoxical paradoxical aciduria. And this is one of the most important questions that do come. Okay. After that, how do you want to treat the patient? You just want to first correct dehydration. You want to correct the dehydration. You want to correct the alkalosis. Okay, you want to correct the alkalosis. After that, you just give n by 2 saline, or you give Ringer's lactate, and you give KCl because of hypokalemia, and then you give dextrose. Okay, so that the sodium absorption is increased and you do not need RAS to be activated. Okay, if you want, how do you want to do the surgical procedure? Okay, you do a Ramstead pyloromyotomy. So pyloro means pylorus, myotomy means cutting the muscle. So what you do is that you, let's say if this is the muscle, okay, and this is the lumen. So what you do is that you keep the mucosa quite intact, okay, and what you do is that you cut and retract, okay, you cut and retract this entire part, leaving the mucosa intact. So basically think of it as a tire, okay, a double tube tire. You cut the outer part of the tube, okay, and the inner part of the tube just comes out, making sure that the lumen is enlarged. So what happens now is that because you've cut this part, okay, because you've cut this part, this mucosa is going to come, and this, you have so much lumen left, okay, and this is obviously retracted, so all the muscle is out, and this is the lumen. So this all in yellow is the lumen. So you have made the lumen larger. If there is no event, okay, now after this you can start feeding in 24 to 48 hours. Let's say if the mucosa is injured, so you'll repair it and you'll start feeding in 24 hours. If it's not injured, if mucosa is not injured and the mucosa is intact, you start feeding in 4 to 6 hours and you discharge the patient. That is about it for a very important topic. Let me just highlight a few important points. Patient is normal at birth, no bilious vomiting, no protein allergy, malnutrition, projectile vomiting. USG is the drug investigation of choice. Double bubble sign on X-ray, single bubble, and due to vomit, as I already explained everything, hypokalemia, chloremia, and stuff like that. And obviously there's going to be bicarbonate loss, but because of the aldosterone mechanism, because of the aldosterone, as you can see here, because of the aldosterone that is causing excretion of the H plus ions, the urine becomes acidic. So this is paradoxical aciduria. I think that is it about hypertrophic pyloric stenosis. Thank you very much.